Good morning, everyone, and welcome to our winter webinar series sponsored by the Early Intervention Training Program at the University of Illinois Urbana-Champaign. We will be offering today our webinar called The Perfect Journey Home, and this webinar is presented by Dr. Bree Andrews, who is an Associate Professor and Director at the Center for Healthy Families in the Department of Pediatrics section of Neonatology. Welcome, Dr. Andrews, and we look forward to hearing more about you and your presentation today. We also have online our moderators for today, myself, Maria Maddox. I am a professional development consultant with the Early Intervention Training Program. And also joining me is Alyssa Jones, who is our Instructional Design and Technology Coordinator at the university there. We will be working behind the scenes, helping make sure that all the webinar technology works fine and that you can all hear and all of this technology stuff that goes along with it. I'm guessing that most of you joined because you want to listen to this awesome topic about this perfect journey home and then maybe get some credit for it as well. So just some details about that. We are offering EI credit for this training, and also you will get state licensure credit if you're an OT, PT, SLP, social work, nutrition, and dietitian. At the completion of the webinar today, at some point today, you will get a survey in the mail, in your email, and complete that survey. That survey is basically our evaluation of the webinar. Once you complete that evaluation survey, you will then get a certificate of attendance within 24 hours after you have completed that survey. So just be on the lookout at some point today for an email from the training program that includes that survey. If you are online as a group, make sure that you have registered individually so that you can individually get that survey to get your credit. If you've participated on webinars before with us, great, then you already know how to do all this stuff. But if you haven't, I want to go over a couple of different aspects to webinar participation. So webinars are great in that, especially on a day like today where somebody said it was a balmy 15 degrees in Dale, Illinois. That's great, because right now it's 0 in Springfield. But what's nice about webinars is that you don't have to go anywhere. You can just sit at your computer. You didn't have to get in your car and drive miles and miles and hours to get to a training. But the downside to webinars is that I can't see you, you can't see me, I can't read you as a presenter to know whether or not we're on the same page and things like that. So we try to come up with different ways to engage each other and to make sure that we're all kind of following along together. So on the left-hand side of your screen, you should see at the top it says audio video. You've got your section that says participants and your name, and then there is a box, or 4 boxes actually, right below your name. We're going to skip the first couple and go directly to the third one. The third one is a hand raise tool. If you click on that box, your hand will raise, and if you click on it again, it'll go down. So I see some folks have found that. If you can find that real quick, click your hand. We may ever so often have a couple questions from our presenter to ask how many of you have ever experienced weather that is like this before, and it'll be a show of hands. And then in order to lower your hand, you just click it again, and your hand lowers down. Okay? That is going to be one way that we will seek some engagement with you. The next way that we'll see about engagement is through the chat process. So at the bottom of your screen, you should have a chat box, and many of you have found that already. And Millie, not sure that works in the app. So yeah, if you're on your phone using the app, some of those things may be different. I honestly have never tried it in the app. I need to do that. So it may be in a different spot, but if you can't respond, you can certainly always respond in the chat box. So the chat box will be where you're going to ask questions since you don't have the ability to talk to us like I have right now to you, what you can do is use your chat. So use your chat box to ask any questions that you may have with the presenter, share any experiences, any strategies, respond to polls if you don't have that function in your app, any of those kind of things. Anything that you would use normally to communicate in a face-to-face, just use it in the chat box. So with questions, feel free to type in your question at any point in time, and we have question breaks built into the presentation so that we can address those questions during those points in time. There may be some questions that you might ask that Dr. Andrews is going to be addressing later on in her presentation, so we may hold off on getting to your question at that point in time, but others we'll try to deal with during those question breaks. The fourth way, or the next way to communicate with us and to engage with us is through the polling function. So back up under your name, that fourth box under your name, right now it should have a letter A in it. That's our polling function. If you click on that box, it should give you a drop-down box that gives you choices of A, B, C, D, or E. Sometimes it'll be the multiple choice letters, sometimes it'll be yes, no. So you can see on the screen, I have a poll on the screen wondering who all is participating with us today. So if you click on that fourth box, open up the drop-down box and identify who you are on our webinar today. Okay, we'll give folks a few seconds to figure that out, find that. And like I said, if you don't have that ability on your app, please put it in the chat box. So we've got some folks identifying themselves in the chat box. Thanks, guys. Okay, just a few more moments. Okay, let's see what our results are. So, Dr. Andrews, it looks like for today you have a very good mix of participants in the room. You've got several Child and Family Connections office staff with a mix of a variety of different disciplines within here as well. And some dietitians in here, looks like some folks from the training program themselves, a bunch of different folks. So we've got a really good mix of folks here today. So great, thank you so much for participating. Whoever has typed in there, when you signed in, you typed in EITP webinar, the perfect journey home, instead of your name, so you can't find, so your name won't be there. So your name is now EITP webinar. Welcome. All right, I think that takes care of our introductions. If you have any other questions, please feel free to use them in the to type them in the chat box. And in the meantime, Dr. Andrews, I'm going to turn it over to you.
Welcome, everyone. I'm really excited to be here with you. I think this is a really productive way to use a very cold day in Chicago and across Illinois. I'm a neonatologist by training, and my specific area of expertise is NICU follow-up, so I interface with early intervention quite a bit, and I'm really grateful for all your services. One part of my job is to really link NICU care to home services and try to make that a really fortified system. And I'm going to talk to you today a little bit about what made me come to this, and then how we do it at the University of Chicago and possibly as a model for other programs. So we'll start with an informal poll, because this is how I got involved with neurodevelopment and NICU follow-up. So how many of you have heard of Barry Brazelton? You can do a show of hands.
Yeah, just raise your hand. Yep. Ooh, we got quite a few folks.
Okay, good. And I will show you, let me see how many, I'll show you how I know Barry Brazelton. So this is an article from September 1974. Barry Brazelton was coming to Chicago, and my mother was a Tribune reporter, and they said, you know, your assignment is to interview Barry Brazelton. And she said, they said, well, my mom said, I won't be doing that. He'll be coming to my home and running playgroups. So as was common, I had to be a uninvited and invited guest to all my mother's ideas. And so this is me in the foreground, where he's holding out the ball to me, and I'm about 18 months old. And she asked him a couple key questions. One was, does every child need a lovey, or an attachment object? And he apparently said, no, they can grow up fine without one. Well, she didn't reveal that she had never given me one, because she wanted me to be kind of a feminist with all sorts of different toys and things. But I was imprinted with neurodevelopment early on from very grade Wilson. So the objectives today are to outline the process of discharging a high-risk neonate from the NICU to a step-down or community setting, to highlight the multidisciplinary nature of NICU care, both inpatient and outpatient, to discuss the developmental trajectories of NICU graduates, and to identify areas of research and innovation in the field of NICU discharge. In terms of my disclosures, I'm the lead medical advisor to PreME&U, which uses mobile technology to engage parents at the NICU bedside, and I will not be talking about this work in the webinar. So this is a little bit of a poll, which is, have you ever been in a neonatal intensive care unit, either as a provider or as a parent or family member of a child that you know?
So you can use the polling function and identify the yes/no, but I see some folks are raising their hands, so we can do that as well. So
yep.
Either way is fine. Looks like we've got a handful of folks still raising their hands and marking yes or no, so we're all good. Let's see. Quite a handful of folks that have said that they have actually been in a NICU.
Yeah, and maybe haven't. So I'm going to try to kind of recreate what the NICU feels like to providers and parents, and to kind of remind you how that sets the stage for our 0 to 3 program. So about 400,000 infants are born premature, less than or equal to 36 or 37 weeks. But the majority are in the late preterm group, which we don't currently automatically serve through early intervention. Extended hospitalization is likely, and only a small fraction of NICU infants die in the NICU or from complications of prematurity, unlike in our adult counterparts, where about 50% of patients who enter the medical ICU would die in the ICU. That's also a really good point. It kind of raises the point about how we spend our resources. Most resources in the NICU are spent on babies who will live and be meaningful members of their families. A lot of people ask, why is there an increase in prematurity? It's increased because of enhanced reproductive technologies and the resulting multiple births, which don't always get to term. It's increased among inner city minority families, and also amongst those that are teens or delivering older than 35 years. And I'm seeing a pretty big disparity between multiples that are born, naturally born in minority populations, and those that are born through IVF or reproductive technologies, because it costs so much to have those services. So there are pretty big socioeconomic disparities between natural born twins or triplets and those that are born through IVF. In terms of the maternal factors that contribute to prematurity, if you've had a previous premature infant, you're much more likely to have another premature infant, either because of your health conditions or because of the physical nature of your cervix and uterus. There could be pregnancy complications, including chorioamnionitis, diabetes, and preeclampsia, and then a number of fetal factors, where there are fetal anomalies or concerns, or amniotic fluid disturbances, or simply preterm labor. Preterm or complicated birth, really in the biggest sense, represents disrupted bonding. The infant is moved to the NICU quickly without typical rituals. Early information about the infant is difficult to comprehend. The father or the family is often in charge of getting to know the baby in the medical situation, and few families have experienced the care of an infant or anyone in the ICU. So once this has happened, once we have a sick infant, all those typical rituals fall away, and we kind of come to the culture of the hospital, which is quite different and unexpected for most families.
Dr. Andrews, I'm going to interrupt here for just a second, and I just want to ask folks that if you aren't on mute, I should have everybody muted, but if you're not, can you please make sure if you're on phone that your phone is muted so that we're not hearing any other background noises. So please check your phones and make sure you're all on mute. Sorry for the interruption. Thanks.
So this is back to kind of establishing the tempo in the NICU, and I'm going to talk probably more about this than you might want to hear, but I'm trying to give a sense of what families are going through. So there's a lot of roller coasters of ups and downs in terms of medical information and conditions we know that are associated with prematurity or with the birth of a child with congenital anomalies in the NICU. But hopefully the family becomes accustomed to the NICU environment and the care team. Infant medical problems are identified at birth, but often new ones surface while some of the old ones are getting better or possibly worse. So it's, I think families often feel like they can't get their bearings. And prognosis is still quite difficult. Estimating the discharge timing and the effects of chronic illness aren't perfect. So one thing I love about these photos on the right are they show how do you engage with families. Families are much more permitted to come to the NICU than they used to be. In the old days, doctors and nurses took care of NICU infants and parents stayed away. And now we have parents right there with us, thankfully, trying to learn all the care and do helpful things for us and get to know the baby. But we also use a lot of our other resources, including our child life programs. Most of the major NICUs, the level 3s and 4s that we know of, especially in academic settings, have child life, child life specialists within the NICU that doesn't go to the rest of the hospital. So they're really looking at the unique aspects of NICU care. We use PTOT nutrition every day. Our social workers are assigned every baby in the NICU. We use a lot of tools for bedside communication, including daily rounds and the establishing of a primary nurse. We just implemented kind of routine family meetings, not just as they're needed, but scheduled ones for parents at 2 weeks, 1 month, and 60 days to try to remind parents that we're there to answer all their questions, not to just tell them kind of the newest problem or the day-to-day basics. And then we make introductions to subspecialists. A lot of our families need subspecialists in the hospital and then need additional help once they've gone home. So we really try to connect the family to resources, and I'm going to talk a lot about one of my areas of interest, which is really connecting families to public benefits and making that kind of a staple of what I do in terms of medical care. But we host parent nights, we establish primary nursing, we have lactation consultation and support in the NICU, and we try to, with them, think through the unique problems of starting your lactation process only through pumping, because that's most of what our families do, and we use donor breast milk, as do a lot of other centers, for the smallest babies who need feeding when the parent's milk isn't yet available. We have Kangaroo Care programs, and our hospital has, through Child Life, has done Kangaroo-a-thon, which is how many consecutive hours can you kangaroo care. We do feeding therapy and feeding planning. I think these two, enrollment in Social Security and attainment of medical insurance, are really important, and that's in the public benefit spectrum, but is to try to make families really experts in what public benefits they qualify for. So in Illinois, Social Security, the absolute birth weight, and this is good for all of you interfacing with families, you have to qualify for on the medical side, and then you have to qualify on the income side. So I am not privy to the income side. Our social workers help with that. But on the medical side, for prematurity, all you have to have is a birth weight less than 1,200 grams, which is a pretty interesting standard. It's a great standard. It's very objective. It's very easy to obtain. to get just what was the weight of birth. I do tell my residents and fellows that I don't want to see anyone who weighs 1,205 grams. I want everyone who's close to 1,200 grams to weigh 1,199 grams, because that's how you get Social Security in Illinois. But as you also know, the absolute requirement for early intervention in Illinois is less than 1,000 grams. So trying to help our systems and our parents understand what the different enrollments are. Most patients should enroll in their medical insurance program within 30 days of birth, like all of us. But that's really hard to do when you've just been discharged from the hospital and your baby's quite sick. And choosing which insurance and which style would suit you best is difficult. And so a lot of times we are struggling with that. A lot of our families who qualify for Social Security will ultimately be able to get Medicaid, straight Medicaid, which is easier to use in Illinois than the HMO program. So we're often trying to get at that piece as early as we can to help families get their attainment of medical insurance early. We train families in CPR. We do car seat programs. I know Caring Bridge, one of these two, Caring Bridge or Caring Pages, has stopped operating, but trying to give parents tools for communicating with each other and their families about their infant's care. So time courses in the NICU really inform what our tempo is going to be like for families. So for most infants born low birth weight or late preterm, it's often just 2 or 3 weeks. That being said, 2 or 3 weeks is much longer than most people have ever had to have a first-degree relative in the ICU. For our VLBWs, our time courses are about 40 to 60 days, and they can be quite extended for our ELBWs. So, our kids who are staying 60 to 150 days really need a lot of support. These are families that all of us are seeing in clinic and in EI, and these families really get affected by living a lot of their life in the hospital or worrying about their child who's living their life in the hospital. For kids who are older or closer to term, but with other neonatal morbidities like HIE or who need ECMO, the time course can be much shorter, but we'll talk in the next slide about kind of how you manage that. So if you have a longer stay in the NICU, I think there's a lot more fatigue from families, and there's much greater risk of impairments and complications for the child. But a shorter stay in the NICU doesn't mean you're going to necessarily be better, so you have to hit the ground running, but the risk of impairment or death is not as imminent. So I try to remind people of this. The NICU is the most stressful place in the universe. Ask the nurses, ask the residents, ask the parents. A study out of Stanford and Duke looked at parents, and the vast majority of parents whose children have spent more than 2 weeks in the NICU display features of post-traumatic stress disorder. And that when you're meeting them, either on the inpatient side or the outpatient side, they are suffering in a way that's hard to understand. And they may not act or have the capacity, they may not act entirely normally, and they may not have that capacity or regain their capacity to function well until much later. And so just trying to be empathetic to families because they are really suffering too. So I try to help families reset expectations about when they're going home, how they're going home, what we can do for them once they get home, support the interventions that they need, but also the progress that babies make. The great news about babies is they almost always make progress. I always tell our residents, every day that the child is still in the ICU is a really good day for them because they're still alive. Their momentum is toward health, which is the blessing of working in the NICU. If you go to the ICU, adult ICU, every day an adult is still in the ICU is a really bad day for them. It means they couldn't get out to the ward. They aren't getting better. But every day in the NICU that you're still alive and doing a little bit better is a really good day. So that's the good side of the NICU. Our hospital isn't offering PhD level psychological supports for parents yet, but that's quite common to try to address this kind of parent functioning piece at the psychological level. So who has experienced, this is a poll, yes or no, right, Maria? Who has experienced working with families while their infants are still in the NICU?
Yes, you can use the poll.
Have any of you been able to, work with families in that transition period?
So go to the polling function, the fourth box, and you should see yes or no option there. We'll give folks a few minutes to decide what their answers are. Let's see. It is the fourth box with the check box in it. I think we can probably go ahead and post the results. Let's see what we got. A few folks have. It looks like there's been some yeses on the chat box as well, but the majority have not worked with families while they're in the NICU. Thanks for responding, guys.
Thank you. Can some people who have been able to do that tell us how it worked? You know, did you get an assignment from EI, or did you have dual appointments in the NICU or in therapy services? Because I'm really curious. I'm hoping to create more connections like that. What we do, you can respond in the chat box. What we do now is that we refer patients based on the zip code to the CFC. We teach them about it in the weeks before they go home, and we make our referral about the day after discharge, because we really don't want EI resources used on parents who aren't home yet, because a lot of times discharge is anticipated on one day and the child may not go for another week or 10 days. But it's made my outpatient life much simpler, because I know that our inpatient folks are doing some of that great work before they go home.
So we're getting several responses in the chat box, and it looks like the majority of folks have had experience with the NICU outside of their EI roles, so as a volunteer or as a parent themselves, a sibling had surgery. But then there are some folks that have done some child find in the NICU, and a lot of folks that have worked immediately after the family's been discharged. So, I mean, it sounds like most of them are getting their contacts with families in the NICU outside of their EI role.
Wonderful. I'm really intrigued by that, and I'm hoping we can make that happen more often. I know that's a lot to ask with all the schedules that you already keep, but I think it's an interesting way to build continuity for our families in the NICU who will go home and really benefit from your services there. So in terms of managing expectations inpatient, and I think probably the most important area for all of us is outpatient, but we give daily details tempered with both reassurance and concern. We evaluate the family and their capacity to manage certain problems both in the NICU and at home. Some of our discharge planning has to do with, can families adequately use oxygen at home, and can they do they have the resources to administer feedings at home by G-tube or NG if needed. We evaluate the capacity of the care team. We can meet frequently with families and consistently, but some families are better served with infrequent but powerful meetings about big decisions, especially if families have limitations in child care for their other children or in terms of transportation. And then we reset expectations as they arise. These are some of the common conceptions that parents have in trying to think through expectations. Inpatient, inevitably, families who are waiting to go home say, I just want to be at home. I can do it better at home myself. And I say to them, I am sure there are many things you can do better at home yourself, but I don't want to overburden you with things that are difficult to do at home. And I need to make it as easy as it can be for you to function at home. I need you to be able to do this without being overly stressed. And taking care of a well baby is hard. I need this to be manageable for you. In terms of outpatient, I hear often, the baby does so well off the oxygen for a few hours, I know he doesn't need it. And I'm always kind of excited by parts of that, which is that presumably they're trying the child off oxygen and it's okay for little bits of time. But one way I manage home oxygen is to say we want to make slow changes at home because we don't want bumps in the road. So bear with me. Let's start with a few hours, but let's keep it just at that. And use those few hours for doing really fun things in the family, which are harder to do on oxygen. But let's keep the oxygen on overnight where the baby will really use the oxygen to breathe easier and grow better. And that means that ultimately won't need oxygen as long and the baby will be healthier in the long run. So I usually try to honor every expectation that parents have. They're usually absolutely right in terms of the general sentiment, and then trying to get at how can we work together. In terms of our contact points for parents, our inpatient medical contacts are daily on rounds. We try to use a single voice or contact person on our rounds. Our rounds are big. In that first frame, you could see the NICU bed spaces. In that space, we have about 20 people coming to hear usually a resident present to the attending physician about the overnight details with additional guidance from our pharmacists, our social workers, and other subspecialists who stop by to make sure we've got things tweaked the right way. Our bedside nurses are amazing, and they have a routine of setting up primary nursing such that almost every day they work, they would be with the same baby. So most of our infants have a day and a night primary nurse. And that's great because once the families go home, those nurses will call me and say, so-and-so's worried, oh, I'm not funny. So-and-so's worried about this, and I know because I've known them for a very long time, which is great. And I think that really helps families feel more secure. Our physical therapists come about 3 times a week to see parents and family and babies, and they make a physical therapy care plan. Our speech and swallow group, once our kids are feeding by mouth, can come as often as they can if they need to help with feeding, but also to create guideposts for feeding at the bedside. Our social workers come especially around both kind of bedside therapy or bedside talk treatment, and also around supports for medical benefits and public benefits. And then our Child Life team has really embraced care boards and schedules, and they really work to make sure that parents' expectations about how the baby is handled are communicated effectively to the team, which I really like. And then our case management team is working continuously, but really building as kids are about 2 weeks from going home. And then I come about 1 time in every 2 to 4 weeks to the bedside to talk to families who are most likely to come and see me just about how we're all connected, and that I'm listening about the care of the infants every, I go to a discharge meeting every week. I think that's coming but in the talk, but just for them to know that we're all connected. In terms of contact points for caregivers, we have medical and discharge planning weekly to discuss progress, prognosis, and barriers to best care and outcomes. Our subspecialty groups round at different time points, but a lot of our families with surgical subspecialty needs will know that team quite well too. We have case conference in our academic group every week, and we bring difficult cases or difficult decision-making problems to that discussion, trying to guide, kind of different decisions that are on the harder end of the spectrum to make sure that we have consensus about how we're treating our patients. And then we're always thinking about what are the transitions going to be to new settings, either from our NICU to Lara Vida. Lara Vida serves as a step down for us for patients who need complex home management, so our treatment kids, kids who are trying to establish whether they need surgical interventions for feeding. And so, we're really thinking about whether their families should transition there and about when they're going home. I think this is kind of what we asked before, which was who's had the opportunity to connect with a family before the child goes home from the NICU. I assume this is about the same as the last poll.
I agree. So we can move on with the
Marie, yeah, do you want to take a minute for questions, or
you know, I can. There was one question that Susan asked, because you mentioned about PT and SLPs. She wants to know if your OTs are involved as well in the NICU.
You know, we just, as it turns out, we don't have as many OTs. So our PTs are doing a lot of that role. And I don't entirely know why from a staffing perspective that is. But we have mostly PTs. A lot of times PT and OT are kind of in the same have the same service orientation in our hospital. So to me, in our group, that therapy service is kind of lumped, but it's mostly in our hospital. Just happens to be PTs, but who are trained for infant development and positioning and kind of early infant movement.
Okay.
Does that answer the question?
I think it does. I mean, you know, there's a lot of reasons why staffing can be affected. Jessica wants to know how you encourage primary nursing. What she has found with supercritical patients is that nurses are sometimes resistant to picking them up for fear of she wrote for fear of loss, so I'm not really sure, but just the fear of picking up these really tiny babies.
Yeah. You know, interestingly enough, our nurses, day and night, we employ 200 nurses to staff our NICU, 25 at a time, half during the day, half at night. We have a lot of depth in our nursing staff, which is so good for us. So I don't think critical illness is our big dilemma. Our nurses are pretty used to, we have about 1 death a week in the NICU at the University of Chicago, maybe 1 every 2. So that part's not so hard for us. I think what turns out to be harder for us is the family demeanor and the family capacity. We have had difficult parents where the nurses are happy to take care of the infants, but they're not as happy at the bedside so consistently. And I think that is a challenge. I can certainly see it both ways. So I think both in terms of level of illness and parenting personalities, it might be easier to rotate through some of those more difficult cases. So for the most part, I'd say probably 65 to 70% of our infants have primary nurses who need them. You know, I'm not sure it's as important for a baby who's only going to be in the hospital 2 weeks to have an assignment of a primary nurse. Probably we wouldn't, it's just not as necessary that those parents can manage when a different person comes in every couple of days. We also have, we kind of stratify our nurses. So I'd say about 60% of our nurses see themselves as kind of intensive care level 3-4 patients on our units in the second floor. And some nurses really prefer feeder and grower kind of patients or patients with lower acuity on our 4th floor. And so that also kind of makes it such that you have what you need when you need it. But yeah, we are working on that as a strategy to make sure that our highest acuity patients have primary nurses over time. I think it does help that there's day and night. I think it does help that our nurses are very seasoned in terms of acuity. But I would like that for everyone, and I can see why it's difficult.
One other, it's not really a question, it's more of a comment, and this comes from Lynn, actually 2 comments. She talks about, because she lives down in southern Illinois, and a lot of those children are sent to you know, the critical care hospitals in St. Louis. So they become technically Missouri residents, and it's hard to enroll kids in EI in Illinois when they're in the NICU in Missouri. And it's also hard then to make connections with families in the NICU if they haven't been enrolled in EI yet. So there's just some of these dilemmas that we run into.
That's absolutely fascinating. Yeah, exactly right. I am on the State of Illinois Perinatal Advisory Committee, and our Illinois network are connected to St. Louis, and that's something we really should look at. We may have to kind of ask our delivery hospitals to do some of that tracking, but I think it does validate the point that it is good to have tracking, and it is good to know who those patients are early, because that helps the different PFCs plan for what's going to be needed in the coming months. So no, that's fascinating, and I will take note of that and think about that with our group. One thing the state of Illinois is doing, and I'm not sure if most of you are aware of this, but we're going through a rule writing process that's going to take about a year, where we're adapting the AAP levels of care, which much further delineates what hospitals have to have in place to do different things in the NICU. And this may be one thing that we can kind of add to our list, which is how to stay connected to early intervention. It's always been true that if you're a level 3 hospital in Illinois, which will become level 4, there will be, some hospitals will remain level 3, and the highest acuity ones will be 4s. But in the past, all level 3s have had to have NICU follow-up. But it may be also that all level 3s should be making these connections, even if they have to refer out to a level 4, because that would get more continuity.
Can you just clarify level 3 versus level 4?
Yeah,
that question's come up a couple times.
Yeah, currently all high acuity hospitals in Illinois are level 3. We only go up to level 3. AAP levels of care will say that there are level 3s and level 4s. 4s will offer also specialty services, ECMO, and kind of the highest acuity services. And level 3s will have a lot of services, but won't be required to have quite as many, not full surgical and some specialty services. So a premature making progress, even if born at 23 or 24 weeks, will be able to stay in a level 3. And level 4s will be, for higher acuity patients like the 23-week infant who hasn't been able to get off the ventilator for 90 days. It's not that, and level 4s can take care of anyone they want to, but there will be more rules around that and guideposts for that. But it will give even more structure to how we care for infants in Illinois. And it's all based on outcomes. It's all based, the AAP reviewed safety, morbidity, and mortality regarding where kids were cared for at the time of birth. So it really is to get babies to the right places to be cared for properly. Okay, great.
Yeah, I think we can move on now. Thank you.
Yeah. So I think this is where we all sit. I'm an outpatient person for the most part, and all of you are as well. So I really try to identify patients early who will follow up with my outpatient team. I take notes every week on all the patients who are likely to come to my clinic. I even start priming outpatient charting, asking people to modify their problem lists and different things in patients so that that it's really straightforward when patients come to the clinic. And I really try to get abreast of what the dialogue has been about medical and social complexity of the patient, and thinking about what I can accomplish before the patient goes home. I think there was a push about 10 years ago where they said, everything should be handled in the outpatient setting. And I keep thinking to myself, why? We only have them for 40 minutes. We should try to do as much as we can inpatient because they're right there. They're 24 hours a day available to us. That's one thing. That's one way I have decreased the amount of time it takes me to see a new patient in the clinic, is that I hear about every patient I will ultimately see every week while they're in the hospital. Okay, sorry, a little bit is advancing. So we try to identify primary care providers as early as when a child becomes 1,500 grams. We try to find the family's comfort level with ongoing care and capacity, and also geography. Geography is a big deal. Our hospital serves all the way down to Kankakee. So we get referrals from Kankakee, which is really very far for primary care, so really trying to think of how to do that well. And the new dilemma that we're all facing is what kind of insurance families have. Not all hospitals are taking all styles of the Medicaid HMO. So at Laura Vida, I can see anyone who has Medicaid, and at the University of Chicago, I can only see patients who have Illini Care and County Care. So just trying to make sure that the family has a place to go that fits their needs and that they can get there is tricky. We're trying to identify home health agencies, pharmacies, and nursing groups that can assist families, especially for more specialized medications and needs. And we discuss this every week in our follow-up group. And we try to introduce families to the primary care team when we can. This really helps pace the families. And then we are trying to really help families room in when they can before they go home. We don't have nesting rooms per se in our hospital, but we do have some private rooms where parents can stay to think through how does 24 hours of infant care feel when the timing of feedings and medications are really important. Oh, this is our question break.
Yeah, I think we can probably move on.
Sorry. I thought it was naturally a little bit early. Is there anything else people want to chime in about?
I haven't seen anything else come in right now, so let's go ahead and move forward, and then any questions that come in we can address at the next one.
Okay, great. So now we're going to really move into this part about infant and neonatal and early childhood developmental trajectories. So this is a graph, and I can see if I can use my pointer, that shows gestational age on the x-axis and the percentage of full-term brain weight on the y-axis. And you can see that even at about 30 weeks, the percentage of full-term brain weight is only 50 or 60%. So we are working with pretty fragile brains in the NICU, and that really aren't at their full capacity. And so the children are experiencing a fair amount of physiologic disruption while their brains are still growing. And that's really impressive and to me, and very humbling. Here is a picture of how the brain looks both morphologically in the bottom, so how it's folded and the shape of it. And then on the top, you can see this is looking from the skull inward, from the top down, at the way the neurons and axons are connected. And I think all of us would agree, the 40-week brain looks pretty spectacular, right? It's got a lot of amazing folds and intricacies at the growth level, and at the cellular level, a lot of amazing connections. But the difference between 20 and 35 weeks is pretty striking, and that's the brain that we're trying to nurture in the hospital, and we're trying to catch that brain up once the baby gets home. So again, humbling for all of us who do this. We'll talk about cerebral palsy a little bit. Probably all of you know more about it than I do, but it's an umbrella term. It's a group of non-progressive but often changing, and that's challenging, I think, especially for parents. It's a motor impairment syndrome secondary to lesions of the developing brain, and it can be lesions that we can't see. So that's, I think, one of the biggest dilemmas with it. And occurs about 70 times more frequently among infants born extremely low birth weight compared to infants born at term. This is the most important slide in this whole talk. And it's mathematic, and so I'm going to try to kind of demystify it. But it basically states that for every birth weight group, a child will have a baseline risk of cerebral palsy but that the risk of developmental delays overall is much higher. And I think all of us have dealt with this, which is that most parents and people think of cerebral palsy as the main problem that happens after children are born preterm, when in fact cognitive delays and behavioral delays are much more common and can overlay and be on top of cerebral palsy. So parents will come to us saying, I'm very worried that you say that the baby is stiff. And in my mind, I think to myself, yes, and there may be other delays that we're going to see that may be ultimately much harder. And so this is a really take-home message slide. You know, at the baseline, a term baby has about a 0.1% risk of cerebral palsy and 5% risk of other delays. But that when you get to less than 750 grams, there's a 50% risk of cerebral palsy, but a 50% risk of delays. And the most common cognitive delays are ADHD and autism spectrum, and often behavioral problems are much harder for parents than physical delays. So that's my soapbox today. So because there's some degree of physiologic hypertonia normally, in the first 3 months it may be difficult to diagnose early developing spasticity related to cerebral palsy. But children who will later develop cerebral palsy often initially have hypotonia and only later develop spasticity. So I always think to myself, what is truncal tone like and what is extremity tone like? However, spasticity during the first 3 to 4 months is a poor prognostic sign. Persistence of primitive reflexes may also be a sign of early cerebral palsy. And mild hypotonia or hypertonia persisting in 8 months usually can resolve by the second year. It may be a sign of more subtle neurologic dysfunction. Now, this is a little bit of a poll. Do we have a poll in here, Maria? I think it's a poll. Are any of you using or have been trained in fidgety movement assessment?
Just raise your hand.
Raise your hand.
Just raise your hand if you have.
Yeah. If any of you are either using it, have heard of it, have access to it. Okay, it looks like not very many, but I'm going to teach you a little bit about it.
Yeah, it doesn't look like very many at all. So.
Okay, good. Well, I'm glad we're here. So Presto is the lead in a group out of the Netherlands. And basically, that group characterized infant movements as first kind of dance-like and flowing in up until about 44 to 48 weeks, and then that the joints get fidgety. And that if you videotape children or watch children, that they start to make small fidgety movements that are normal. And if either those kind of dance-like infant movements aren't dance-like or the fidgety movements aren't fidgety, it's a very early sign and highly predictive of cerebral palsy. And so a lot of us in the academic networks are trying to this is a little bit of an error. It says fidgety movements are the types of movements that normal babies make between 3 and 5 months of age. But we're trying to really use objective evaluations of babies to try to predict early cerebral palsy by using fidgety movement assessments. The fidgety movement group, the biggest group in Chicago is out of Northwestern now and out of Shirley Ryan. And they're trying to promote an app whereby parents can take the video of the child and the video gets scored so that parents have kind of an early assessment. And I think what's interesting about fidgety movements is it pulls our diagnostic ability earlier. And then that improves our ability to intervene, which is great. It also leaves open some painful discussions for parents about what do we know so early. Because I think a lot of parents are really relieved when they get home because most babies act like babies, which is great. I think for parents' emotional well-being. And this adds a layer of early diagnostics that both I think can be really helpful for clinicians and for therapists, and that pushes that conversation a little bit earlier. But I think all of us will see more use of fidgeting movement assessments in the near future. So in terms of classification of major neurologic disabilities, obviously cerebral palsy is one major neurologic disability. That being said, spastic diplegia is the most common and not necessarily very severe. Spastic quadriplegia or spastic hemiplegia is much less common, but is more major or more morbid for children. Hydrocephalus with or without accompanying cerebral palsy or sensory deficits, and with or without BP shunting, and then blindness or deafness and seizures are the major classifications of neurologic disability. In terms of intellectual outcomes, they can really differ depending on your neurologic diagnosis. Most children with spastic quadriplegia have severe impairments in speaking and cognitive function, while children with spastic or hemiplegia may have better mental functioning. And cognitive function is not always really measurable until 2 or 3 years of age, especially among neurologically impaired children. So we're really trying to get as many of these kids connected through early intervention to medical diagnostics early, so that they have connections to specialists as they get older, when early intervention isn't available. A lot of times, if we can create that new appointment while early intervention can serve a family, that means that return appointments are much easier to get amongst high levels of specialists, and that makes it much more functional for families. So most neurologic problems either resolve or become permanent during the second year of life. The blessing of working with children, as we all know, is that they can still improve despite having significant diagnoses. And then in the second year, the environmental effects of maternal education and social class begin to play a more major role in the cognitive outcome measures. I'm just on the verge of publishing a paper which basically says that until age 2, your neonatal morbidities have a lot, really are linked closely to your Bailey, and that your maternal education and socioeconomic class doesn't matter so much right then, which means we're doing a great job equalizing the playing field between 0 and 2. Our group also has data, though, that shows that between 2 and 5, a lot of children who are neurologically normal slip and become less able to access school at age 4 or 5, and that a lot of the kids we would expect to improve don't also improve, because we think that for socioeconomic determinants are really impacting families. In terms of IVH, grade 1 or 2 usually resolve without residual deficits. That being said, amongst infants that are born less than 1,000 grams without IVH and without any other neurologic morbidities from the NICU, so IVH, BPD, necrotizing enterocolitis, infection, even with children with none of those, about 30% will have some impairments at age 2. Grade 3 is a marker for motor and cognitive disability. Can someone on the call remind me, is grade 3 an automatic eligibility for EI, or is it just 4? I think grade 3 is automatic eligibility, but I can't remember. So at age 5, 50 to 75% of these will have moderate to severe neuromotor deficits. They can have deficits in visual motor and visual spatial areas, and if shunted with hydrocephalus, more will have disabilities. Oh, I wrote it here. I think I'm right, but I'm not sure this is up to date. And then grade 4 establishes full criteria for ENGO and EI. 90% will have definite neurologic sequelae. 80 to 100% will have major motor deficits, and many will have significant cognitive.
I looked it up, grade 3 and grade 4.
Great. Okay, good. Thank you for re-educating me. I would always make the case for a grade 3 anyway, but that's just because I'm pushy. spastic diplegia is the most common form of cerebral palsy. You all have seen it. I don't know why that's there. Maybe that's, I'm sorry, I don't know why that picture is there. I think it's just maybe out of place. But do we have a minute for questions?
I believe we do. Let's see, there was one question that Riola is asking, what are some suggestions when a child is discharged from the NICU and immediately referred to EI to encourage bonding before a new team starts with a family? So the question is, should the EI program allow for some time for the families to bond with the child prior to starting the intake process? And if so, what would be an appropriate amount of time?
Gosh, that is a really good question. I think if we let it go too long, the parents start to think it's not that important. You know, I have not seen a lot of drawbacks in having an assessment within a couple weeks of the child coming home to the house. I always tell parents at my first visit, this is the name of your CFC, this is the phone number and fax, they should be calling you, and when they come, you're going to have an incredible group of people who know how to help you get to know your baby at home. And even if your baby's doing quite well, they're going to show you some things that are very hard to show you in the hospital. What are great positions at home? How do you work with your furniture? How do you work with your spaces at home? And parents are usually very reassured by that, and especially parents of multiples. You know, where I said, look, when the EI team is there doing your evaluation, you can, you know, the team can be working with one, and you can be making sure the other one has everything they need in terms of twins and triplets. But I haven't seen huge problems with bonding when the EI team comes early. I think it's more of a drawback if that kind of connection doesn't happen early, because I think then parents, all the other things about their life start to kind of trickle in, and then it starts to be a lower and lower priority, I think, for families. Inevitably, parents get home and there's, you know, someone's job is in jeopardy and the big kids need things, and, you know, then I think it drops in the priority. So I'm not worried about early phone calls, early connections. Parents also are very confused about who's who. So I really try to encourage parents to write down the first and last name of everybody who calls, and which agency they're from, and what the agency hopes to do for them. I know it sounds basic, but I think sometimes that gets lost in translation, and parents are being bombarded by new information.
Could we record what it is that how you describe EI to families? Because that was awesome.
Of course.
Thank you so much. I think that's a great question, because people are hesitant. You know, even though we've got a 45-day timeline, you know, there's still like, do we let the family have time to bond or not? And I love that, the response. Jessica has a couple of questions, and I'm not sure if they're really pertinent to what we're talking about right this moment. I'm going to pose them to you, and you can decide if you want to address them now or later or privately. Jessica's curious about if you're advocating for increasing in nursing home nursing pay rates, and that because there's such a shortage, do you support any of the hospital nurses, inpatient nurses, going into the home and doing some follow-up home care? So I don't know if that's...
I'll tell you, actually, we've got a good program that's been in place about a year now. CDPH has provided our hospital 2 liaisons, and I think many more people on the ground to provide home visits when it doesn't meet the criteria for DSCC home nursing. So those folks are meeting families in the hospital, looking at needs and patterns and things that these kids will eventually benefit from, and then are coming out to the home. It's really, really a great program. Our nurses can't go to the home without a medical indication, like it's malpractice, right? So it's so every person who comes into anyone's home needs to have a reason for being there and a contract for being there. And we don't have a visiting nurse program that's organized by the hospital. We rely on DSCC-approved home nursing visits through the waiver program and waiver and non-waiver programs, and then also some insurance companies, but Medicaid is not one of them, will allow for intermittent home visits. That's not true. Medicaid, I guess, can do some, but very intermittent home visits in the first weeks or months when the kids are home when they don't qualify for those other services. So there are good programs. I think CDPH is the best one right now, though. And it's got a name, but I can't think of it, what the overall program's called. But that's been tremendously helpful to our families.
And she was also talking even especially about the medically fragile, technology-dependent children, you know, because there's such a need. So thank you for that. And then Roberta has a question about families who have transitioned home, but as soon as they get home, they're facing more surgery. So they choose not to start the EI process until all that surgery is over. So is there any tips for talking with parents about getting them connected to EI earlier, you know, rather than later?
Yeah, no, I understand that. I think that's really practical, and I think sometimes that's really necessary just to kind of wait for that process. I don't know if it's possible for EI to say, can we connect with you once a week by phone just to make sure everything is going as you planned, and so such that we don't have a delay in starting when it's time to start. But I think you're right, the non-premature population, the population in the NICU that's more surgically based with chromosomal abnormalities and congenital abnormalities, those kids are often waiting for kind of the next phase. And I think it's really up to the EI teams. If the surgery's 6 weeks out, it still may be useful to see what that kid can do in an assessment. But then, of course, it fragments putting in place a scheduled therapy team, because you don't know when that child will be available again. That is a puzzle that I'm not sure I know how to solve, but a really important one, and I think we all just have to keep working on it.
And I think a lot of us forget that, service coordination, without other services, it can still be part of the plan, so to not disregard just that part of it until the family's ready to start looking at the other services. So I think that is the questions that we have right now. We'll take any other questions that come in at the next break. So thanks. Okay.
I'm going to hustle a little bit. I guess I have more slides than I do time. So a lot of the next pieces are fun pieces. They're kind of innovations in NICU follow-up, so I think I can get through them pretty quickly. Okay, so the family arrives home. I like this family.
That is mine.
Yeah, I figured. So this isn't really that important for you guys, but my clinic runs both primary care with a medical practice and developmental capacity in the same clinic. And I work both at the University of Chicago and La Rabida. I have another colleague who's a neonatologist, a nurse educator, social worker, therapist, nutritionist, feeding specialist. And one of my sites I have infant development, and the other site I have physical therapy. So I have connections to developmental follow-up in EI. But the most unusual thing I have is a lawyer. So I'm going to talk to you a little bit about that. 15 years ago, we were part of a pilot program, and we established a Chicago Medical Legal Partnership for Children. Our lead is Amy Zimmerman out of Legal Counsel for Health Justice. Their group has changed titles a number of times. We have a lot of folks that have worked with us over the years. And we can make daily and weekly referrals for unmet legal needs. And they really have to do with public benefit. So when a child is eligible for something they aren't getting, the lawyer helps us. So this is a caricature of someone like me, and I'm examining a child who's had an ear infection, and I say, that ear looks better, it's recovered, the Japan membrane looks great. And the mother's got tears in her eyes because she doesn't know how she's going to afford the rent or the food or get the kids to school, and there's no money in the bank. And the medical-legal partnership really recognizes that the clinical space is fraught with legal issues that can be managed with legal to specialty care. And that legal care and high-quality medical and developmental care really can examine the social determinants of health, that safe and affordable housing, access to WIC food stamps, Social Security benefits are really important. A lot of families are choosing to either heat their homes or eat because there isn't enough money for both. I am really kind of concerned about FMLA for ELBW infants. You know, what is a parent to do if they're eligible for medical leave when they might be allowed 3 or 6 months? Do they take the 3 months while the child's critically ill in the NICU? Well, they have to take some, right? But then it leaves them very, much less time once the child comes home, where they're having to do it all themselves. So really trying to think through how to best utilize FMLA. We are FMLA miracle workers. I write a mean FMLA letter to try to get parents their rights in terms of retaining their jobs once their child's home and they're back to work. But we can modify social determinants of health, and we really have to educate ourselves about public benefits, and I present each parent with the expectation that they deserve public benefits, that I think is something they deserve, and that means they will communicate with me much more actively about it. I say, you deserve the $675 that's issued by Social Security because you qualify, and that money you can use to pay for a lot of things that are difficult for you right now, and that really helps parents. So we refer when needed benefits are denied. We recognize the power of legal advocacy, that a lot of times no one cares if the doctor calls, but if a lawyer calls, things seem to get rectified pretty quickly. And we can give feedback in both directions about which systems are working well for families and which ones need more help at certain times. And then we use that to work towards greater systemic advocacy, and I'm going to talk about that in relation to, I think, Jessica's question, a little bit about home nursing and what's happened to that in Illinois over time. We used to do this, but we've gotten so much better that we don't do it now. But we used to have a Social Security Administration person to take Social Security applications once a week at Friend Center. Now we just do it ourselves because we're pretty good at it. But that means that once they get home, the family gets home, if they show the birth certificate and the discharge summary, they can expect $600 to $700 per month. And that's equivalent to about 20 hours of minimum wage work per week for 4 weeks. So that might be about what needs to be replaced for a lot of our parents. A lot of the poor families that I take care of weren't working more than that, so at least that can replace some of that money they would have been earning while they're now taking care of their child at home. So this is a great case. I was new to the clinic 15 years ago, and I was made aware that a child was admitted for carbon monoxide poisoning and then discharged. And they came to the clinic for the hospital discharge follow-up. And this baby had been a 25-week infant, so the parents had been through a lot. I didn't know them well. I was new to the clinic. And the child popped up on the table, and I am reviewing the discharge summary and everything. And the parents are strewn about onto the couches, barely able to lift their heads. And as it turns out, they've been home a week, and Grandma said, I really like this 3-year-old, but I don't like these adults too much. I don't want these adults in my house. So they've been sent back to the home. So they had the inpatient team had a safety strategy for the child, but not really for the parents or for changing the carbon monoxide issue at home. So no action had been taken about the living conditions. And I sat there and I thought to myself, these parents appear poisoned, and what am I going to do about it? So I talked to the family. They have a slum landlord, no formal lease. The gas contract is held by the slum landlord for all the spigots of gas for the whole apartment building. So you can't turn off just one. You have to turn off the whole building without, no straightforward cutoff valve for that one unit. And again, these parents have nowhere to live except for this poison department. I thought very quickly about what I could do. And I thought I could start calling. But I've talked to some landlords before. I have talked to people who don't really want to help, and no one cares what the pediatrician says. So I called a lawyer, and she calls the landlord and says, "You're poisoning people. You won't own this building next month if I take you to court." He gets the gas turned off. Our lawyer gets the gas turned off with this landlord. Within 2 weeks, they had cooking accommodations, you know, a hot plate and microwave, and a repaired gas line. I think we probably saved ourselves 50 hours of medical work, because no one would have cared what I would have said, but I would have been frantic about this case. This family comes back 2 weeks later, and the parents are upright. The dad shakes my hand and puts his arm around me, and they're totally normal people. And I didn't know where they were on that spectrum, because they were, you know, asleep in the couches because they were poisoned. But their dignity was intact. They said, they came to me and they said, "We didn't know we didn't deserve this, and we didn't know that it wasn't right. And your folks got us what we need to be healthy." And it's been a really powerful story for our team. I'm going to go back just a second. The story I was going to tell you that I didn't highlight here, but it's about home nursing. So people will probably remember this. 3 or 4 years ago, the state hired an independent group, paid an independent group to go in and evaluate whether each child who had home nursing, mostly through DSCC, deserved the level of hours, the number of hours they had. And amongst all the cases that were reviewed in about a year or 2 years worth of time, every single child had a reduction or an elimination of service. And our legal advocacy group, this is systemic advocacy, said that's not right. And so they put together a class action lawsuit. I think it represents about 100 kids in Illinois. And basically, they were able to say, this wasn't fair, this wasn't done fairly or objectively. And they put a stay on any redetermination of service. So that got all of those kids back to the level of service they had. So the next thing the state did, and this is where it's really a problem, the state said, okay, so now our wage for home nurses is 2/3 what it used to be. So now a lot of nurses won't take those spots. But at least, and now we're working on that part of it, but at least there was a stay of elimination of home nursing services for families. Now the state breaks the support that a lot of people, so you can be eligible for service but not get any, which is also a problem. But our legal group has been at the forefront of trying to mitigate some of those barriers to just medical care. I'm going to talk a little bit about the view from our phone triage line. Probably many of you have been on the phone triage line with the doctor's office. Medical questions are straightforward. Non-medical questions are also somewhat straightforward. I have people call and say, I need a letter for comment, I need a form for the school. And then there are a lot of parents who call talking about things that don't seem to make sense to me, which is, I put it in the, I don't know if it's medical. But I think that what our triage line and what our clinic represents is the culture of chronic illness. We have over-concerned caregivers, we have under-concerned caregivers, we have well-connected caregivers, we have poorly connected caregivers, but almost everyone is somewhat overwhelmed. And just trying to remember that, when we're talking to families, things can be really minor in my eyes, but they've called. They've reached out and said, something is bothering me, and it may seem minor to me, but maybe they're trying to tell me something about how they're functioning. Research can help. So this is really quick, and I only have 10 minutes. I'm going to really breeze through this. I looked at infants, and this is one of the mainstays of my research in my career. I looked at infants born 23 to about 28 weeks from the early 2000s, and we used to think that if you were born at 23 weeks, you were just most likely to be much more impaired than those infants born at 28 weeks. And that's not true. What happens is many more of our smaller babies die, so 50% of 23 and 24 weekers die, and almost all 27 and 28 weekers survive, so that the pattern of disability is very similar among surviving infants. So that if you survive at 23 and 24 weeks, you're much more likely to look like 25 and 28 weeks in terms of overall profile. So this graph shows you that the rate of being normal, so that kind of light blue box in each category, is very similar. It's between about 45 and 60%. Children with a Bailey score of 60 to 69 are in the purple, and those with scores between 50 and 59 are in the yellow. And there's a similar number of kids with severe impairments in each gestational age group. And that has to do with the epidemiology of prematurity, that most of the sickest, smallest babies die. So you're not seeing them out in the clinics and out in the homes. When we look at late preterm outcomes, let's go back 1 second. The one point I want to make about this is because of the epidemiology, it's much more likely that all of us will see more impaired 28-weekers than we do impaired 24-weekers because there's so many more 28-weekers out in the world. So just remember that. Don't be so fearful of a 24-weeker. They're very much like their 28-week counterparts. And you may see more 28-weekers because they're more that have survived NICU care. In terms of late preterm outcomes, a New York study compared 50 late preterm infants to 77 very preterm infants born less than 32 weeks. And our mean birth weight differences in the bigger group were about 2,100 grams versus about 1,100 grams. And amongst the late preterm group, about 30% deserved enrollment and early intervention was needed. And that the most common service needed was physical therapy, followed by occupational therapy. And that when you control for comorbidities, the rate was more similar than we would expect between very preterm and late preterm groups. This is the actual figure of the rates of need of each service, including early intervention overall, PT, OT, speech, and social welfare, social emotional care between the two groups. So I think even though we don't have the direct ability to refer every patient who's late preterm, we really should be looking at that group for specific qualifications and delays that can be put into EI later. All preterm infants need enhanced surveillance, so we do NICU-based surveillance, discharge attention, primary care, developmental screening, nutrition, social work support, parent networks, and legal advocacy. I know we're really short of time. I'm going to skip this. This is straightforward. This basically says that when you look at infants, the kids who, this was based on a functional score called WIDEA, we screened families. The kids who do the best are the ones that are ineligible because they're doing so well and don't receive early intervention. The next group is those that are eligible for early intervention and receive it. And the children with the lowest functional scores are those that deserve early intervention but can't get it because of all the factors that go into what makes it hard for families to get it. So we can improve functional outcomes by providing high-quality services, which I think we all know. Surveillance opens the door. We do a lot of surveillance, as you can tell, in this discussion about who needs what when. And then I think this is probably the conclusion. Oh, yeah. So I'm going to just go right to the end just so you can see it. This is a project I think you've probably seen where a photographer has been helping families get pictures of babies from the NICU and then doing photo shoots with them later. I think it's pretty sweet. We really try to create consistent language, a consistent level of service for families, really prioritizing public benefits and then justice around legal advocacy, and really making our commitment to patients palpable. That's, to me, the NICU journey home, and we're really glad you're there to catch them when they get there. And then let's do questions, and then we'll talk about whether people would like to see more NICUs and would like to be on tours and things like that.
Okay, we've had a lot of questions that have come through here. So I want to start with Jill asks, can those in surrounding suburbs use the legal advocacy group, like out in McHenry County? And so, like, what about those families who don't live in that area?
In my understanding is that Chicago Medical Partnership for Children can take referrals from anywhere. And if they can't serve the family, they will refer it to another pro bono group, usually LAS, Legal Assistance Fund. But yes, I can get you information about how to do that.
Okay, and then what about
mostly for the poorest families, but yeah.
Okay, and then if there are any issues with legal residency, what if the parents aren't legal? That might be a question for the attorneys themselves.
Yeah, no, I mean, they know that that's as much of a determinant of health as anything. They can navigate. The good news about Illinois, maybe, or in general, is that a lot of our public benefits don't check legal status and don't interface with immigration at all. So, I mean, thankfully, I hope it doesn't change. But it's like two systems that are in parallel, but you know, they can function without our kids who need service. Without immigration knowing about our kids who need service, basically, which is fine with me.
Okay. And then kind of somewhat connected, Susan's wanting to know, does the NICU team get cultural sensitivity training when they're working with families of different cultures?
Oh, yeah. I mean, I don't know, our patient population is predominantly inner city, poor, and minority. And I'd say a good portion of our staff is minority or are from these communities, you know, started in these communities, but yes, of course.
Okay. Jessica is wondering if you have considered implementing telehealth for NICU follow-up so families don't have to travel.
You know, I don't have the capacity to do that, but of course. I mean, that would be delightful. Because we're working at the state level for the levels of care, how to help provide unique subspecialties like neurology is in very short supply, how to do telehealth that way. It's hard to know how to manage HIPAA and billing. But yeah, I think, of course, I would love to do more telehealth, but there isn't a mechanism to do it just yet.
Yeah, and then you got to rely on the family's technology as well. So
yeah,
right. Let's see here. Jay is asking, do most hospitals have follow-up teams that find families that haven't connected with EI? Okay, let me read the whole question and then maybe that'll make more sense. Also, let's see, referrals are made to EI, but parents don't return calls and then they get dropped. Jay has a follow-up clinic at their hospital where they find families who have not connected with EI. Do other hospitals have that service?
My hunch is not exactly. Nationally, about 25% of programs do medical and developmental follow-up in the same place. And that at least means that you see the families more often. So if there's a disconnect with EI, you can find it sooner. But every level 3 in Illinois has a follow-up program. You have to by the state law. And then there should be a prescribed number of visits. I think the other hard part, though, is that some of the families that get disconnected from that, too. And so, yeah, I think that tracking is could use more fortification. But I don't think it exists as much as we hope it would.
All right. And one more question. Susan wants to know, when does the infant get checked for cortical visual impairment?
We do a number of different, we have a number of different mechanisms of managing that. Our ROP folks follow our patients really closely. And then we start to look for, obviously, early tracking and visual cue responses. I don't know how you all feel, but I feel like Lighthouse for the Blind has been tremendously helpful. At our hospital, I have a slight disconnect with our ROP specialists because they can say to me, the retina looks fine, the muscles aren't perfect, but maybe they'll improve and we'll patch them. And I say, okay, I need functional vision. And they say, well, you can't come to the Lighthouse for the Blind, they're not blind. I say, oh, yes, I can. I need more functional vision. I need the child to look around and take in the world around. But I think that's been, vision services have been really, really very primary for a number of my patients.
Okay. All right, folks, that's about all the time that we have for questions. I know it's 10:30 now. We just want to wrap up. Dr. Andrews just has a couple of other things just to share if you want to wrap up, and then we'll finish up for the day.
Yeah. You know, it sounds like a lot of you are pretty well connected to NICU resources. If any of you feel like you'd like to be better connected or want to come on a tour, I think I could help arrange that through either my own affiliations or through the state program that I work at. So if that appeals to you, please reach out to me. And I have a few references here. None of them are much more detailed than what I put in the talk. But I'm open to questions and comments as time goes on. Thank you all for spending the morning with us. And this is just such a great opportunity to connect with you all.
Thank you as well. We really appreciate the information and look forward to having you working with us again. So just as a reminder for folks, you'll get that email this afternoon around 2. That's the evaluation. Please complete that and then look for your certificate of attendance within 24 hours after completing that. Again, if you joined, logged on as a group, you will have had to have registered individually, so to get that survey. With that being said, thank you everyone. Our webinar is ended for today. We look forward to seeing you at our future webinars, our winter webinar series. I believe our next one is in a couple of weeks. With that, please stay warm. I think we're finally on a warming trend. It's now 6 degrees in Springfield, Illinois, so I think we're finally getting out of our polar vortex. So have a great rest of your day and week, and happy EIing. Bye-bye.